is Naomi Waithira, and I head the data management group at the Mahidol Oxford Research Unit based in Bangkok. Today, I'll talk about what's in our hand, and that's data, and how we can use data in the fight against infectious diseases. Now, let's track back a few years ago, March 2020. A global pandemic unfolds. Governments, communities, individuals alike are all scrambling for answers. Amidst this chaos, data became a lifeline for a lot of people. Dashboards like the one on the screen became a source of information on a daily basis for many people to track where the cases were being reported from, the number and proportion of cases being reported, the number and proportion of deaths, and at a later stage, we could also track vaccination rollout progress. Now, countries which had robust data systems and capacity to use that data were able to adapt their policies and direct resources to where they were most needed. But that wasn't the case everywhere. Now, COVID slowly slid into oblivion and new threats emerged, such as the Mpox outbreak recently in parts of Africa. Again, health authorities are looking at the data to understand how many cases are reported, where they are reported, the severity, and then using that information to a certain extent to influence control interventions and resource allocation. So data can be quite a useful tool in improving decision making. But not just that. While data has been useful in tackling present diseases, it can also be used to predict where future outbreaks may occur and help to save lives through targeted interventions for these particular high-risk areas. Take, for instance, cholera in Yemen. In 2017, the World Health Organization reported one of the worst outbreaks ever, where more than 1.1 million cases were reported and more than 2,300 deaths were reported as well. Now, a group of researchers got together. They put together health information, mainly microbiology data, combined that with environmental data, which came from NASA's satellite images, and that included plankton distributions in the sea, because plankton is a vector of the cholera bacterium, temperatures of the air and the sea, and also precipitation information. Now, it's reported that the model had an accuracy of 85 to 92% in identifying areas at high risk of the outbreak. Now, such tools can be incredibly helpful for health authorities and for the public in general to prepare, and particularly in this time where there's a lot of uncertainties and unpredictability due to climate change and its impact on health. Now, in all these examples, one thing is clear. The power of data as a tool to improve health outcomes is possible when data from diverse sources are put together. Now, if you take the example of COVID, data came from different sources. It came from hospital records, it came from surveillance activities, it came from insurance companies, pharmaceuticals, and even patients themselves. However, there was a huge variance in how and when data were shared. And in fact, a study done around the intention to share data from clinical trials conducted in that period showed that only 15% of the investigators had declared an intention to share their trial data. Now, some have attributed some of the failures in our response during COVID pandemic to being a consequence of data hoarding by various entities, including governments, individuals, and corporate. But there are valuable lessons that we can learn from that, key of which data sharing is essential in addressing future threats. But we also do acknowledge that data sharing is not straightforward. There are issues of trust, there are issues of collaboration and equity, and there are also economic factors associated with it. But the onus is on us, and in particular, being researchers based in low resource settings, we ought to make the data that we are generating available for reuse and for decision making. if we don't do that, there is a risk of bias. There is a risk of bias in the estimates that are generated. There's a risk of bias in the algorithms that are generated, or even in innovations. Now, the pulse oximeter has been found to be less accurate for individuals with darker skin tones. AI algorithms developed in the West, when deployed in the South, have been found to perform suboptimally. Why? Because the data used to train these algorithms is not representative of communities in these areas. Now, the frequently cited global burden of disease study relies on modeled estimates rather than observed data for many countries in low resource settings. What are the results of this? It means that these estimates, which are potentially used to influence some decision making, may be inaccurate for these settings. But the question is data scarcity the main problem? I'd like to challenge that. Now, countries like Nigeria, India, Kenya have implemented digital health systems that collect extensive data on population health, on maternal health, and also on disease control efforts. There's also been an exponential growth in mobile penetration in many regions, which has led to an increase in the ability and also the volume of data collected at the community level and also at the individual level, even in remote areas. Perhaps then the problem is not primarily data scarcity. Perhaps the problem is underutilization of existing data. And many factors can contribute to this. In this study that was done around how data is reused in clinical research, particularly in LMICs, there were three key barriers that were identified. One was technical barriers relating to findability and accessibility of data. The second was around data quality resulting from a gap in data management skills. And the third was around governance and equity, who benefits from reuse of data. But beyond that, we know that data has some gaps, and particularly around representation of certain populations. Communities in rural areas or in conflict-affected regions may not be well represented in data. Traditionally, it's been a bit more challenging to conduct research in vulnerable populations due to ethical concerns. That includes children, includes pregnant women, prisoners, or disabled populations. But what that means is that data sets continue to fail to account for these populations. Now, long-term longitudinal studies are a rich source of information, but then they are quite expensive to run, and financial constraints affect the scale at which they can be run and the number of them as well. There are regulatory complexities which arise from legal, bureaucratical, and ethical frameworks. And lastly, data quality concerns over consistency of the data, completeness of it, and accuracy of the data. But it's not all dark and gloom. We can do something about increasing the volume and accessibility of data. The first of which is we can streamline how data is collected by shifting our reliance on paper-based data collection to use of mobile health technology. We can collect data quicker, collect data of higher quality, and also collect data at a greater scale than what we've been able to. There are many affordable, user-friendly, and even open source options that are available, and I'll be happy to guide you through them if you've got any questions. Now, looking back at the data that has already been collected on paper records, we could digitize these records through manual entry or automated reading, such as using optical character recognition systems. Now, having increased the volume of the data that's available, the next step is getting that data to be used. For that to happen, others need to know what the data contains and the context in which it was collected. So publishing and putting together metadata that describes the data sets themselves, the methodologies and protocols used for collection, and making these metadata available more widely without necessarily making the data publicly accessible will increase accessibility and the knowledge that the data exists to others. Now, when we look at what the data actually contains, there are many ways to describe health conditions, treatments, and outcomes. By utilizing controlled terminologies such as SNOMED CT, ICD, which has been used widely for coding diagnosis, LOINC and MEDRA, we can standardize how data are described and what terms are used across different healthcare systems and also between research and healthcare data. And that aids in combination of data and also in inference across data sets. Now, in this age where we are moving more and more into machine learning and automated reading, use of models that are standardized, such as OMOP and CDISC, will greatly simplify data integration and movement between systems. But we acknowledge that data standards and their implementation can be quite a specialized activity requiring effort and the relevant skills. There is a body of research emerging around using AI for data structuring and standardization that could automate these processes as well as making them much more efficient and accessible to others. So as this data is being used and as new tools are being created, there are significant considerations to also make around governance. First, in ensuring that the health benefits are prioritized over profits. Why is this important? In innovations, there is a prioritization in the industry for ventures and tools that are likely to bring more economic benefit. Now, for communities based in low resource settings, it's unlikely that they will be able to afford some of these tools. What that means is that tools that are appropriate for them might not be prioritized in development and rollout. So there needs to be a concerted effort to prioritize the health needs of these communities. Secondly, we need to strengthen regulatory oversight and transparency in how these tools are developed, what data is used in training them, and how they are tested and rolled out. This will not only reduce the chances of harm from tools that are incorrectly developed, but will also build public trust. And in this age where information travels very quickly and is widely accessible, even to children, it's important that what goes out is reliable and is correct. Now, I came across this quote, which I find interesting. I'll read it out and I'll let you internalize it. Greater investments in getting the descriptive epidemiology of diseases and injuries correct in poor countries will do vastly more to reduce uncertainty in disease burden estimates than philosophical debate about the appropriateness of social value choices. All right, so next, let's think about how this data is used, who uses them, where do we use them, what health priorities are put up. This needs to be led by local researchers, and they need to have the skills, the tools, and resources to analyze the data and to act on it. Programs like the Deltas Initiative, the EDCTP and WHO TDR funded programs have shown how targeted investments in training and infrastructure can empower researchers. Furthermore, there's training platforms such as the Global Health Network, which reaches thousands of researchers and health practitioners. We need to sustain and reinforce these initiatives as they go a long way in ensuring that researchers are not just data providers, but are also leaders in global health research. So in conclusion, data is one of the most powerful tools for advancing global health, but its power is neutral. It can either uplift or marginalize depending on how we use it. To realize its promise and mitigate its perils, we must act with intention by prioritizing implementation of the FAIR principles, that is, making data findable, accessible, interoperable, and reusable, and by investing in skill strengthening and fostering collaboration. Thank you very much.